No, good afternoon, everybody. Good afternoon, Mr. Mitchell, please. Thank you. My Lord, ladies and gentlemen, this is the closing statement on behalf of the Scottish Government. In October last year, at the outset of these impact hearings, we gave a commitment on behalf of the Scottish Government to the inquiry process, to the Chair, and to the people of Scotland. That commitment was to assist, to cooperate fully and openly, to listen and to learn. That commitment has not wavered, and we renew that commitment today. In acknowledgement of the likely difficult experience for those who are due to give evidence, we also undertook to listen to that evidence with respect and with consideration, and we have done so. We therefore begin by paying tribute to those who have given evidence to the inquiry and to the courage, humility and candour that they have displayed. It has not gone unnoticed by the Scottish Government. On behalf of the Scottish Government, we also pass our deep sympathies and condolences to the others, the many thousands, who have lost loved ones, who have suffered and who continue to suffer because of COVID-19. In due course, during its implementation and decision-making phases, the inquiry will no doubt examine the situation faced by the Scottish Government, the options open to it, and the decisions that were taken. Evidence may be led from policymakers, decision-makers, and experts. Until then, it would be premature to reach a concluded view on matters such as foreseeability and minimisation of impacts, as I suspect Mr. Gale recognises. What I can do today is to address some of the evidence and to draw the inquiry's attention to points that it may wish to consider as it prepares for future hearings. Firstly, to speak for a few moments in general terms about foreseeability of harm. When the pandemic hit our shores, the first and most immediate priority was to avoid direct COVID-19 health harm. Very early on, it was foreseen by the Scottish Government that the virus had the potential to cause harm in many ways. It must be understood that the complexity of the challenge posed by the rapid spread and evolution of COVID-19 meant that there was no single correct response. There were few, if any, harm-free decisions open to governments, including the Scottish Government. The four harms, that is, the pandemic and the measures in response to it, could cause harm in four areas, were interlinked. This was well understood by the Scottish Government at the time. Measures designed to curtail the spread of the virus reduced the direct health harm, but on the downside risk causing isolation and loneliness, economic upheaval and disruption to education. These devastating effects of the pandemic were foreseeable, but a consequence of avoiding the harm caused by the virus. In these circumstances, the challenge was for the Scottish Government to assess risks and benefits and take decisions to reduce overall harm as much as possible. Turning now to aspects of the evidence led during the impact hearings, and looking firstly at care home evidence. On behalf of the Scottish Government, we acknowledge the severe impact of the pandemic on the social care sector. The evidence on this chapter of the hearings was at times extremely distressing for those who gave evidence and for those who suffered loss. It reflected the concerns of witnesses on topics such as the changing nature of guidance, the isolation experienced by residents, and the continuation of restrictions as the rest of the nation emerged from the pandemic. Evidence was also heard of the experiences of those suffering from different forms of dementia. Anger and guilt were frequently mentioned emotions. The grief of witnesses who were not able to say goodbye to their loved ones was palpable and moving. It has to be remembered that decision-making in this area was detailed and complex, taking place amid a dynamic and rapidly changing situation. In the early stages of the pandemic, due to the concern of the risk of rapid infection within care homes, measures were focused on trying to prevent ingress of infection and on minimising transmission. It must be remembered that at this time there was no vaccine and limited availability of testing. Therefore, it was recommended that routine visiting should be paused, but that essential visits for end-of-life or distress should be supported. The complexity surrounding decisions on visiting was discussed in a report prepared in late 2022 by the Chief Medical Officers of the United Kingdom. The CMOs commented that, and I quote, Reducing risk of transmission in care homes involved some of the most complex trade-offs of risk to individuals of any part of the pandemic. These included considering the needs and rights of individuals as well as those of the wider resident population. This in turn meant balancing the risk of COVID-19 outbreaks in a very vulnerable group with maintaining staffing, access to healthcare, close contact needs of residents, visiting by relatives and friends in what are often the last months of life, and dignity and quality of life among a group with high prevalence of dementia, end quote. Bearing all that in mind, I turn to some of the points made in evidence and in the written submissions. The point has been made that guidance for care homes change frequently. In the absence of specific clinical COVID-19 guidance for care homes and in response to a request from the adult social care sector for specific guidance, the Scottish Government issued such guidance. Understanding of the virus and its effects developed rapidly. There was a clear need to update the guidance as new data and evidence emerged. Whilst recognising that it was challenging for care homes to respond to changing guidance, it was essential for the guidance to be updated to reflect new developments in our understanding of it. More broadly, it is important to have regard to the actual guidance that was produced by the Scottish Government in contrast to the measures that individual care homes chose to put in place. For example, Scottish Government guidance to care homes did not restrict end-of-life visiting. From the outset of the pandemic, the Scottish Government was clear that end-of-life visits should be supported. A focal point of the evidence was that residents should have the right to receive in-person visits. In April 2022, 2 new health and social care standards were introduced that set out the expectation that people living in care homes should be able to see someone who is important to them even during a pandemic and be able to name a person who can directly participate in meeting their needs. But that approach has to be embedded in legislation. The inquiry will be aware that the National Care Service Bill is currently at stage 2 of its parliamentary process. During stage 1, the Parliament took extensive evidence from a range of stakeholders, at which time the ANZ law provisions received in-depth scrutiny. The Scottish Government values the support of Care Homes Relative Scotland in helping develop and deliver ANZ law. It is currently considering the feedback from that organisation, amongst other organisations. This process includes consideration of ways to strengthen ANZ law, as well as assessing the potential for alternative legislative mechanisms to deliver ANZ law more quickly. Evidence was given regarding a lack of consultation between the Scottish Government and care sector representatives prior to the taking of decisions or issuing guidance. In fact, there was widespread consultation at senior official and ministerial level with care sector groups, relatives and unpaid carers, in addition to stakeholder participation in a range of Scottish Government-led social care advisory groups. Of course, where urgent decisions or guidance was needed, consultation might not have been as detailed or lengthy as would otherwise be the case. And as with any consultation, a range of views would often be provided, not all of which could be accommodated. Turning to long COVID, the inquiry has heard evidence of the pernicious impact of long COVID on the lives and health of both adults and children suffering from the illness who have struggled to have their voices heard, have faced difficulties in obtaining a diagnosis, and suffer feelings of isolation and abandonment by the medical profession. We wish to reassure the inquiry and long COVID sufferers that the Scottish Government is taking steps to improve their lives. It is committed to ensuring that every person with long COVID is supported with access to the care they need in a setting that is as close to their home as possible. We mention here an initiative of the Scottish Government called Scotland's Long COVID Service. It has 4 key elements: supported self-management, primary care and community-based support, rehabilitation support, and secondary care investigation and support. These elements are supported by the establishment of a £10 million long COVID support fund. NHS health boards are responsible for delivering services to meet the needs of people suffering from long COVID in their areas. The fund will ensure the right support is available within primary care, providing a response focused on each patient's needs, with referrals to secondary care where necessary. A total of £6 million has been made available from the fund over 22 to 23 and 23 to 24, and a further £3 million is being made available in the current financial year. Turning to the impact on care providers, charities and the third sector. The Scottish Government recognises the dedication demonstrated by all care workers during the pandemic. Care workers in the private and public sectors and in charities, as well as healthcare workers, made sacrifices and continued to perform important services during the pandemic. The inquiry heard evidence on behalf of the charity Promoting a More Inclusive Society, or PAMIS, which provides help and support for people with profound multiple learning disabilities, PMLD, and their families. The inquiry heard evidence that the former Cabinet Secretary for Health and Sport, Ms Freeman, sent a letter in November 2020 to a number of health and social care providers in Scotland, emphasising that for hospital visiting purposes, carers should not be regarded as visitors and that persons with complex care needs should receive the same level of social care in a hospital setting as they received in the community. The intention of the Scottish Government and of the letter was clear. The level of person-centred social care to an individual should remain consistent regardless of whether they are in the community or in hospital. The evidence given on behalf of PAMIS was that this problem existed prior to the pandemic and indeed continued during it. The Scottish Government will examine whether it should have taken stronger measures to assist people with PMLD to achieve a consistent level of social care during the pandemic when they were admitted to hospital, and if so, what form those measures could have taken. We heard evidence that families and unpaid carers, described as the forgotten army, are an essential part of caring for those with profound and multiple disabilities, and that they considered that decision makers did not understand the impact of their decisions on the people for whom they cared. The Scottish Government recognises the contribution that unpaid carers and the third sector have made to the pandemic response and societal recovery. It has listened to the evidence that charities should be treated as partners of government and of the NHS when dealing with any future crisis. Working to design services with the third sector, with those who have lived experience, and with stakeholders is a vital part of the Scottish Government's ongoing programme of work to establish a national care service in Scotland. In our written statement, we have addressed the evidence led on children's rights and lack of personal protective equipment. Both are were significant areas of evidence. But in view of the time remaining to me, the inquiry will forgive me if I direct interested parties to our written statement on those topics. In so doing, I do not mean to reduce the importance of the evidence given, nor the significance of the issues to those affected. Turning to our final thoughts, the pandemic was, of course, unprecedented. But what was also unprecedented was the loss suffered by the Scottish people and the contribution made by them to the Scottish Government's response to the pandemic. We have heard evidence of the trauma experienced by members of the public, by healthcare and social care workers, key workers and their representatives, and by members of the third sector. But there was also an unprecedented contribution by the people for the greater good of society, from those working in social care and the NHS, from key workers, and from the voluntary and charity sector. Much of the evidence in the health and social care impact hearings has been given by those who said they were neither heard nor listened to. Over the course of the last few months, we have heard evidence from unpaid carers and those living in supported accommodation. We have heard moving evidence from those who were denied visiting rights to visit their loved ones and the emotional devastation that this caused. The Scottish Government understands that the most important way to recognise the loss and suffering of the people of Scotland is to learn from the evidence, to identify what could have been done better and to improve government decision making. With that in mind, these witnesses should therefore know that the Scottish Government has listened to their evidence. On behalf of the Scottish Government, we pay tribute to those witnesses who exhibited such bravery in making the decision to come forward and to give evidence to this inquiry. Thank you.
Thank you very much indeed, Mr. Mitchell. Now, we'll next hear from Ms. Toner on behalf of the Care Inspectorate. Ms. Toner.
My Lord, good afternoon. My Lord, on behalf of the Care Inspectorate, The submission is made with reference to the evidence as it has been heard from October of last year, concluding last month at the impact hearings on health and social care. And the scope of that evidence, my Lord, led at the hearing was, in terms of the inquiry's direction and opening statements from September of last year, the impacts of the strategic decision-making in relation to the theme of health and social care insofar as are matters related to the inquiry's terms of reference. And the Care Inspectorate, my Lord, offers its closing submission on the basis of that evidence as it has been heard and at this stage, my Lord, and in its continuing efforts to assist the inquiry. My Lord, during the impact hearings, evidence was led from a number of witnesses who spoke of their experiences with relatives and loved ones who resided in care settings during the time of the pandemic. And the evidence spanned impacts within the health and social care sector on both a personal level and also at an organisational level. And my Lord, insofar as the witness evidence made reference to any involvement or interaction with the Inspectorate, the principal issues in my submission which emerged from that evidence were first the nature of the role of the Inspectorate, and secondly, my Lord, the process of inspection and advice from the Inspectorate during the pandemic. And my Lord, it will be important for the inquiry to have a full understanding of both matters in fulfilling its terms of reference, particularly in the context of the impacts of the strategic elements of the handling of the pandemic in terms of the inquiry's terms of reference. And in particular, my Lord, it will be vital in my submission for the inquiry to fully understand not only the procedures of the Inspectorates, but also, my Lord, the limitations upon its powers, both generally and in the wider context of the pandemic. Evidence was led from a number of witnesses to the effect that care home inspections during the pandemic developed a focus on infection prevention and control, and that had a negative impact upon both residents and staff. And further, my Lord, evidence was led of discrepancies in advice between the Inspectorate and Public Health Scotland. And my Lord, it will be important for the inquiry to understand the changes imposed upon the Inspectorate to its inspection framework during the pandemic, particularly in the early part of 2020, and the significant efforts, my Lord, made by its staff to comply with those changes during what was, on any view, a very challenging time. The Inspectorate will provide the inquiry with full information to allow these matters and any other matters with which it can assist to be examined carefully at future hearings in order that the role of the Inspectorate and the constraints under which it worked during the pandemic can be placed in their proper context. And lastly, my Lord, the Inspectorate reiterates that it will continue to assist the inquiry in whatever way it can so that the inquiry can fulfil its terms of reference thoroughly and expeditiously. My Lord.
Very good. I'm very grateful. Thank you, Ms. Turner. Now, we'll next hear from Scottish Care, Ms. Berg.
Good afternoon, my Lord.
Good afternoon.
Scottish Care has lodged detailed written submission on the evidence heard by the inquiry in this phase of its work, and I adopt those submissions in full. Time does not allow me to cover all of the matters contained in those submissions. Instead, I will focus on those matters which Scottish Care considers should be highlighted, and these are broadly grouped into 5 themes relating to the impacts of guidance in the social care sector, visiting restrictions, the withdrawal of healthcare services from care homes, the experience of social care staff, and the social care sector being under-resourced and undervalued at the outset of the pandemic. Before turning to each of those, I would like to take this opportunity on behalf of Scottish Care to thank all of the witnesses who have given evidence to date, and also to acknowledge the losses many experienced during the pandemic, and also the challenges faced by those receiving social care, their families and social care staff who worked with dedication throughout the pandemic. It is recognised that the inquiry is in its first of 3 stages relating to health and social care, and much more evidence will be heard. It is also recognised that not all evidence will be heard orally. Nevertheless, Scottish Care wishes to highlight that limited evidence has been heard to date in relation to social care services delivered in the community by those who deliver and receive them. As the majority of social care in Scotland is delivered at home, it is essential that sufficient evidence is heard to allow lessons to be learned from the impact the pandemic had on service users, providers and staff in the care at home sector. Turning to the first of the themes I have mentioned, the inquiry has heard evidence about the impact on the social care sector of the volume of guidance produced and the frequency with which it changed, not least in placing significant pressure on staff. It was inevitable that guidance would be required to be updated as the pandemic progressed. However, the initial failure to summarise the changes in each iteration meant that care home managers had to scrutinise updated guidance to identify the changes which then had to be communicated to staff. This process added to the burden of care home managers and staff and diverted them from providing care to residents. Witnesses also spoke of occasions when guidance had to be updated shortly after it had been distributed because those in the sector identified problems with the guidance or its implementation. This caused confusion and at times frustration, which could have been avoided had the care sector been consulted prior to the guidance being issued. Guidance often indicated a lack of understanding of the care sector by those responsible for producing it. Elizabeth Martin, a registered nurse and GMB representative, described the frustration she felt in reading guidance, which seemed to be written by people who did not know or understand how a care home works. It is submitted that seeking input from those with expertise in the provision of social care would have helped to ensure that guidance issued was fit for purpose. The guidance often did not take account of the variety of service settings in which social care services can be delivered, nor was it framed in a way which allowed staff flexibility to make assessments about what was in the best interest of those they cared for. Viv Dickinson, CEO of Crossreach, described feeling like the guidance was coming down in an NHS directive model rather than in a way which took into account the nuances of different settings. In Scottish Care's submission, the care sector's professional expertise and capacity to make decisions taking account of such nuances were not recognised. And this lack of recognition was also visible in the visiting restrictions and the increased scrutiny of the care home that occurred during the pandemic. Guidance also failed to take into account the realities of living with or caring for someone with dementia. For example, it did not take account of the propensity of those who live with dementia to wander with purpose, or the fact that residents with dementia may not understand why they are being asked to socially distance. Implementation of guidance in such circumstances had the potential to cause real distress. Witnesses, including Dr. Donald McCaskill, CEO of Scottish Care, gave evidence about the impact that isolation and social distancing had on residents, particularly those with dementia, for whom routine and physical touch is so important. Alzheimer's Scotland and others also spoke of cognitive decline that those with dementia experienced during the pandemic. The evidence that the inquiry has heard in this phase of its work indicates that the impacts of dementia were not sufficiently understood by those responsible for producing guidance for the care sector. Scottish Care considers that such impacts could have been reduced had input from dementia care expert been sought, and respectfully submits that the inquiry should seek input from such experts to support its investigations. On the theme of visiting restrictions, the inquiry has heard evidence of the significant distress restrictions caused to residents of care homes and their relatives, and of the trauma experienced by those who were unable to be with their loved ones when they died. At the outset of the pandemic, Scottish Care supported visitor restrictions and it advised its members to lock down in advance of the national lockdown as a precautionary measure. However, by April 2020, it was making representations that restrictions should be relaxed. Scottish Care continued to advocate for the easing of restrictions and called for a human rights impact assessment to be undertaken in relation to the restrictions. The inquiry has heard evidence of some care homes taking a more restrictive approach or being slower than others to reintroduce visiting in a meaningful way. Evidence has also been heard about why some care homes considered it necessary to take a more cautious approach, including the risk of prosecution resulting from Operation Copper. Witnesses described the pressure on providers to make the right decisions in face of conflicting guidance, combined with pressure from residents and family members to see their loved ones. Jennifer McEwen, a Director for Voluntary Services Aberdeen, referred to considering, when making decisions, whether she could stand up in court and justify the decisions that she made. Staff did not want to keep families apart and at times found enforcing restrictions distressing. They were often under significant pressure to admit visitors and were criticised in the media for enforcing restrictions that they did not create. The lack of clarity of the status of guidance caused confusion and, in Scottish Care's view, put care home managers in an invidious position. The inquiry has heard evidence from family members of residents who expressed the view that as it was just guidance, care homes could choose to depart from it, whereas insurers made conditional cover on compliance with guidance and trade unions, focused understandably on protecting their members, sought to challenge providers who departed from it. Due to its inflexible nature, Scottish Care considers that acting in accordance with guidance prevented providers from being able to make a human rights-based assessment in relation to visiting. Care homes also had to consider the wishes of relatives who did not want visitors to be allowed access, as they considered that this would expose loved ones to a greater level of risk. The inquiry has heard evidence that on occasion changes to visiting guidance were publicly announced at lunchtime briefings prior to such changes being communicated to the social care sector. This led to care homes receiving queries about guidance which they had not yet seen and put additional pressure on staff to implement changes quickly due to the expectations that such announcements creates for relatives who were understandably desperate for changes for visiting to take effect. Care homes could not always respond immediately to changes in guidance. In some areas, they required their plans to be signed off by local public health teams. Independent Care Home Scotland gave evidence about the delay that this could cause. It is submitted that the harms caused by visiting restrictions could have been mitigated had the Scottish Government undertaken a human rights-based assessment at an early stage of the pandemic. Adopting guidance which provided for a designated visitor for each resident, as first called for by Natasha Hamilton of Care Home Relative Scotland, with visitors also being required to comply with PPE and testing requirements, would have been a proportionate approach. This would also have provided clear and balanced guidance for care homes to implement. Turning to consider the impacts of withdrawal of healthcare services from care homes. Scottish Care has provided evidence of the sense of clinical abandonment experienced by staff when GPs and other health professionals ceased to visit care homes. Social care providers have also given evidence about the impact of the lack of physical assessment had on residents as a result of primary health care services transferring to telephone appointments. Guidance issued by the Scottish Government also created an impression that there was a blanket ban on residents who were COVID positive being transferred to hospital, which persisted even after the guidance was clarified. Witnesses have spoken of ambulance refusing to take care home residents to hospital. Care homes, unlike nursing homes, are not designed to provide clinical care. It is submitted that it was foreseeable that a withdrawal of healthcare services for residents would increase pressure on staff and lead to a deterioration in the health of residents. Moving to consider the impact of the pandemic on social care staff. The level of fear experienced by the public at the outset of the pandemic, when the nature of the virus was unknown, must not be forgotten. Social care staff continued to care for others despite being frightened, or as some witnesses have said, terrified, they would take the virus home to their families or transmit it to those for whom they were providing care. In community settings, this was compounded by seeing NHS staff visiting service users wearing full PPE when guidance did not yet provide for PPE for social care staff. Social care staff also witnessed unprecedented levels of death in the initial months of the pandemic. Staff often develop close relationships with those for whom they provide care, which was particularly important during the pandemic when residents and service users could not see their relatives. Social care staff also lost colleagues to the virus. The inquiry has heard evidence of the significant trauma experienced by those in the sector. Staff and managers worked long hours, taking additional shifts to provide cover when colleagues were required to isolate. They had to take on additional responsibilities, including complying with increased infection prevention and control requirements and new reporting requirements. And staff also missed the valuable assistance that visitors provided when caring for their loved ones. The pressures encountered by staff has led to burnout and staff leaving the sector, creating further staff shortages. The inquiry has heard evidence that those in the care sector felt second class when compared with NHS staff. Furthermore, care-at-home staff felt invisible throughout the pandemic. They did not feature in conversations taking place on a national stage in the way that NHS and care home staff did. Family members also provided evidence about the treatment of care workers. Dr Whiteman agreed when asked by Mr Gail KC that those who worked in care homes were unfairly treated or castigated, noting that care homes were treated as isolation hospitals. The impact that the pandemic had on staff, health and well-being is significant and continues to have a detrimental impact on the provision of social care in Scotland. This brings me to the final theme that I wish to address in my oral submissions: the impact of the social care sector being under-resourced and undervalued at the outset of the pandemic. The inquiry has heard from a number of sources that there were significant staff shortages in the care sector prior to the pandemic. Scottish Care agrees with the evidence from Royal College of Nursing that the pandemic brought into sharp focus major problems that predate the beginning of this crisis, and also that the problems care homes have faced during the crisis have in many respects been symptoms of how the sector and the people that live and work in it have been undervalued by society for far too long. It is submitted that it was foreseeable that a sector which was undervalued and under-resourced prior to the pandemic would be severely impacted during it, particularly in light of the increased responsibilities, increased scrutiny and reduced support from external agencies. Unless I can assist your Lordship further, that concludes my submissions.
Thank you very much. Excuse me. Thank you very much indeed, Ms Burke. Thank you. Right. I think we've reached the first scheduled break, so we'll take 15 minutes now, and then when we come back, we'll hear from the College of Paramedics. So 15 minutes. Now, as I said, the College of Paramedics, Miss Donald. Thank you.
Good afternoon, my Lord.
Good afternoon.
My Lord, my client, the College of Paramedics, was grateful to be invited to make a closing statement, which was duly submitted to the inquiry. I adopt the contents of that closing submission and ask that it be read alongside the closing statement and ask that it be read alongside the opening statement previously submitted. The opportunity to supplement the closing statement orally is also welcomed, particularly as we're able to do so in light of the other core participants' written statements, which I, my instructing solicitors and my clients have had regard to. I don't intend to do this at length, but simply to highlight some points where there appears to be a similar approach amongst some of the parties. Firstly, my Lord, my clients have instructed me to be very clear that the college and its members consider it to have been a privilege, a great privilege, to have supported the public during the pandemic. They took their supporting role very seriously. In my written submission, written statement on page 2, I refer to the first report on the Let's Be Heard project, where a paramedic had reported how difficult it was taking a patient away from their family in an ambulance as an example of impact on our pre-hospital care team. And that came from the inquiry's own report. I've previously submitted on behalf of the college that the guidance coming out from the Scottish Government and their advisors to have been one size fits all, and I'm quoting from somebody else's submission there, with no account apparently being taken of the different working environments across the wider healthcare sector. And this is a submission which has found a community of thinking with other core participants. For paramedics, there was no specific guidance for those working in the constricted space of the ambulance, described as a box. For care homes or care at home, we've referred to them variously, it's been submitted that they too felt the guidance was directed at the clinical setting and did not take account of the fact that the care home was actually their resident's home. That was referenced earlier today by Mr. Gale. There appears to have been a lack of consideration or understanding of specific workplace challenges, and that is clearly the position of my clients, the College of Paramedics. The guidance, others have referred to this, the guidance was also constantly being updated, understandably updated as matters moved on and changed, but constantly being updated with the consequent difficulties of understanding and communicating changes. A subject many core participants have referenced, and mention is made of the Friday afternoon dissemination being a particular problem. I've been asked, instructed, to emphasise the importance to the college, on behalf of members, of the need to ensure that never again should paramedics, in common with other frontline medical staff, particularly paramedics responsible for frontline pre-hospital care, often of very seriously unwell patients of unknown etiology, never again should they have to fight for respiratory equipment or suitable protective equipment. The uncertainty over the provision of such equipment in the face of changing guidance or advice added to the extreme anxiety paramedics were subject to, when at the same time dealing with very anxious, understandably anxious and worried patients and families. The shortage of PPE at the beginning of the pandemic and the concern that caused is again a common theme amongst a number of core participants. My Lord will recall mention in my written submission at page 5 that the college carried out a survey of Scottish members, and that did show that the majority of the responding paramedics, the Scottish paramedics, did not feel confident that they were well protected. My Lord, I have referenced a couple of times other parties or other core participants, and largely those who make similar submissions to those I make on behalf of my clients are Scottish Care, Scottish Healthcare Workers Coalition, Scottish Hazards, Crossreach, STUC and Scottish Hazards again. They get a double mention. The importance of recognising the clamour from a number of parties as to the route of transmission where the government, well, both governments, were focused on transmission by droplet and not the airborne route, is something my clients again would like to see recognised and later explored in evidence. Again, that's been referenced by Mr. Gale rather helpfully this morning. That lack of earlier recognition of the airborne route of transmission caused difficulties with the provision of PPE, or appropriate PPE, to paramedics and others. And it caused the focus to remain on the hierarchy of controls, which I set out on page 3 of my written statement. The RCN and Scottish Hazards also comment on difficulties caused by the failure to recognise airborne transmission, and the College aligns itself with their comments. In future sessions, it's my submission, it will be helpful to hear from those responsible for not patently acting on the growing body of evidence of the airborne transmission route to understand why the response to that was so slow and what their competing evidence, if any, was. My Lord, I would like to draw attention to one last element of the written statement at page 6. Reference is made to the written reference of one witness. That witness didn't give evidence orally, but that statement and supporting papers has been provided by the widow of a paramedic who had caught the virus early in the pandemic in March 2020 and subsequently died. That paramedic was sent into a house without knowing that the prospective patient had recently returned from Italy. And it's my submission that that evidence and the supporting papers shows the human impact on the paramedic profession as part of the wider health profession. And in my submission, it's important that this is reflected at every turn of the inquiry's work, as it appears is the intention of the inquiry from this morning's oral submissions. In concluding these remarks, my Lord, I think it's relevant for me and of interest to the inquiry to inform His Lordship that I am advised by my clients that the inquiry is being closely followed by their members across the UK, not only here in Scotland. Ms Nichols, the Ecology CEO who gave evidence to the inquiry, has received very many messages of support and thanks from paramedics who are grateful to have had their voice and their concerns heard here in Scotland, not yet heard in England, although it's anticipated Ms Nichols will give evidence to the UK inquiry later this year. We felt it important that the inquiry appreciate that the work thus being done by the inquiry here is being seen to have a much wider influence and impact elsewhere. My Lord, those are my submissions.
I'm very grateful. Thank you very much indeed. Now, the Royal College of Nursing, Ms Shand.
My Lord, the Royal College of Nursing in Scotland extends its thanks for the opportunity to have participated in and contributed to the inquiry in respect of the health and social care impact hearings. It is grateful also for the opportunity to have this oral closing statement made on its behalf. As the inquiry is aware, the Royal College of Nursing in Scotland is the representative voice of nursing across the 4 nations of the United Kingdom and is the largest professional union of nursing staff in Scotland, nursing in the world, the Royal College of Nursing, my Lord. It is a registered trade union. The Royal College of Nursing in Scotland is a distinct directorate operating within the UK-wide Royal College of Nursing rather than as a separate legal entity. Over 48,500 of Royal College of Nursing members are based in Scotland from a UK-wide and international membership of over 500,000 registered nurses, student nurses, midwives and nursing support workers. Members of the Royal College of Nursing in Scotland work across NHS hospitals and specialist health facilities, in care nursing homes, the community and private healthcare sector, amongst others. On the 24th of October, an opening statement relating to the inquiry's impact hearings was delivered on behalf of the Royal College of Nursing in Scotland. It had earlier submitted a written submission which set out in detail what it hoped to achieve from this phase of the inquiry and the varying impacts on its members, bearing on terms of reference 2A to I. The Royal College of Nursing in Scotland thereafter submitted witness statements on behalf of the organisation from 3 senior office holders, Colin Pullman, Norman Provan and Eileen McKenna. On the 20th of March 2024, these 3 witnesses attended the inquiry and delivered oral evidence expanding on the points raised in these statements. On the 17th of June, the Royal College of Nursing in Scotland submitted a written closing statement in which it addressed the impacts that it considers were A, foreseeable, B, most significant and or detrimental, and C, might have been minimised or excluded had reasonable steps been taken to do so. That written statement also identified what future investigations and further evidence the Royal College of Nursing in Scotland considers would be necessary for the inquiry to complete its consideration of the pandemic decisions and implementation measures which resulted in or failed to minimise the impacts identified. In accordance with the direction of the Chair, this oral submission seeks to draw to the Chair's attention matters of concern addressed in the organisational witness statements, oral evidence and written closing statement, which the Royal College of Nursing in Scotland believe required to be highlighted in order for the inquiry to complete its consideration of the matters referred to in its terms of reference. These matters are as follows. First, the understaffing of the nursing workforce. Prior to the pandemic, there had for a number of years, to the knowledge of the Scottish Government, been high numbers of unfilled nursing vacancies within the NHS Scotland and social care sector. The whole-time staffing required to provide a good level of service was in deficit at the start of the pandemic. This was significantly exacerbated as a result of the pandemic. Because of staffing issues, nursing staff required to be redeployed during the pandemic with no additional training into unfamiliar clinical environments, including intensive care. Student nurses, amongst others, were mobilised to address the shortfall. These initiatives led to staff being made to shoulder more responsibility than they were equipped for. Factors such as these caused mental health problems amongst the staff concerned. So too did the general burden placed by the pandemic on nursing staff, having to work harder and longer in difficult circumstances in an already understaffed workforce. As a result, to RCN's knowledge, many health and social care staff are experiencing significant and complex mental health issues as a result of the pandemic. Further, across the UK, the prevalence of long COVID among staff working in health and social care is significantly higher than in the wider population. There are nursing staff who contracted long COVID who have been unable to return to work or have had their working hours reduced. The impact of long COVID on the workforce, along with continuing psychological symptoms being experienced by many RCN Scotland members, means that there is a cohort of the registered nurses and nursing support workers now unable to practice or who have had to reduce the hours they work. Not only has this impacted on their earnings, but RCN Scotland's position is that this reduction in staff has had a consequential adverse effect on the quality of care capable of being delivered to patients and care home residents. RCN Scotland's position is that without an adequate number of nursing staff with the right mixture of skills who are able to deliver the appropriate standard of patient care to meet the demand of the country at the present time in the absence of a pandemic, then there is no prospect of the demand created by any future pandemic coming close to being met. On the matter of long COVID, which I mentioned, the RCN has this month written, RCN Scotland has this month written to the First Minister seeking an amendment to the current terms of reference to the inquiry to explicitly include long COVID. This is with a view to ensuring that evidence about the foreseeability of long-term post-viral symptoms, such as those arising from long COVID, the impact of long COVID on individuals, and its impact on the already depleted nursing workforce, are fully part of the inquiry's investigations and report. Second area I wish to highlight, my Lord, is the adequacy and hierarchy of the provision of PPE. From the beginning of and throughout the pandemic, RCN Scotland regularly expressed its concerns in correspondence to the First Minister of Scotland regarding the difficulties its members had in accessing adequate supplies of PPE. Care homes were particularly affected by a lack of PPE due to not being able to access their usual supplies and suppliers. RCN Scotland consider that the evidence has highlighted that there appeared to be a hierarchy in terms of the supply of PPE. RCN Scotland members were reporting that they considered there was a prioritisation of PPE, in particular of the more so-called heavy-duty PPE, such as FPP3 masks, in the intensive care units and some parts of the acute sector. PPE in the care home and community care sector, both in relation to the procurement and provision thereof, was considered by RCN Scotland to be inadequate. This inadequacy resulted in RCN Scotland members having to reuse PPE, which was intended for single use only, or in some cases procure their own PPE. Further, the one-size-fits-all approach in the design of protective equipment had been a problem for frontline health workers who had to wear this life-saving equipment for up to 12 hours at a time. Face fitting was an issue, as many people had not been properly trained to carry out this. And this was exacerbated by the fact that a number of brands were not producing masks which fitted female faces, nor took into consideration workers who may have religious headwear. As a result of issues of this type, the masks were often ill-fitting for those individuals, and as a consequence, the masks did not form a seal and allowed air to get in at the side of the mask. RCN Scotland contend that it was a foreseeable consequence of insufficient and or ill-fitting PPE that it would increase the likelihood of contracting the virus. RCN Scotland observes that a further recurring concern expressed by its members was in relation to the confusion regarding the guidance on use of PPE. The evidence led supports the position that the guidance on PPE changed frequently, leading to confusion on how to apply it. Many RCN Scotland members reported that this caused them a dilemma over whether they could or could not treat patients without wearing PPE. The frequency at which PPE guidance was updated caused inconsistency in its application, which in RCN Scotland's view will undoubtedly have contributed to the transmission of the virus. Third, my Lord, mode of transmission of COVID infection. Intrinsically linked to the issues of adequacy in the type and provision of PPE were the consequences of the Scottish Government strictly following the advice of antimicrobial resistance and healthcare-associated infection, RHI, an advisory group which continually reported that COVID was a droplet-spread infection rather than an airborne infection. Health boards therefore only routinely offered higher levels of protection, such as FFP3 masks, in the areas where aerosol-generating procedures were routinely performed. From early in the pandemic, the RCN raised this issue throughout the Workforce Senior Leadership Group, that's say RCN Scotland, throughout the Workforce Senior Leadership Group and other pandemic strategic management groups established by the Scottish Government in the early stages of the pandemic, and on which RCN was represented amongst others. RCN Scotland carried out an independent review of the literature that was emerging in this regard and considered that the evidence was clear that the transmission of the virus was airborne. RCN Scotland wrote directly to the Scottish Government, citing international evidence to support its position, but the Scottish Government continued to favour the view that the virus was transmitted by droplet. Ultimately, the World Health Organization acknowledged that COVID is an airborne infection. RCN Scotland considers that had the Government approached this issue on a more cautious basis, it is likely that it would have had an impact on the recommendations of what protective equipment staff should have been using and when. The final issue to be highlighted at this stage, my Lord, is the approach to the application of reporting of injuries, diseases and dangerous occurrences, Regulation 2013, colloquially known as RIDOR. In terms of the effect of the pandemic on nurses, the RCN in Scotland and across the UK is concerned by the failings that led to a lack of RIDOR reporting. RCN Scotland repeatedly experienced resistance from health boards to the suggestion that they should be reporting to the HSE, the Health and Safety Executive, incidences of COVID which appeared to have been acquired at work. Some of these health boards dismissed the suggestion that this could happen, stating it would be impossible for staff to contract COVID at work as they had been provided with PPE. After the issue was raised with the Scottish Government did provide guidance to NHS boards on reporting to the HSE via the RIDOR process, where staff may have occupationally derived COVID. However, that guidance suggested that a PCR test, that is to say a polymerase chain reaction test, should be completed by staff. PCR tests could only be analysed in a laboratory. However, by this time, by the time the guidance was issued, PCR testing was not the methodology that was being used by health boards for staff to test, as it had been replaced by the self-testing process. This anomaly likely meant that there will be many of the workforce who contracted COVID at work whose infection was never reported because a PCR test had not been undertaken. Thus, the potential for the Health and Safety Executive to be more involved with Scottish Government and employers was lost. RCN Scotland contend that had there been more stringent reporting mechanisms, there would more likely have been more stringent control mechanisms, which would have decreased the number of people contracting COVID-19 in the workplace and decreased also the number who went on to develop long COVID. In conclusion, my Lord, RCN Scotland looks forward to receiving the findings of this phase of hearings, which both serves as a reminder that the impact on our professionals in the health and social care sector was considerable and must not be forgotten, and provides the opportunity for important lessons to be learned. Thank you, my Lord.
Thank you, Ms Shand. Now, the Scottish Healthcare Workers Coalition. Mr Webster, please.
My Lord, Mr Gale, good afternoon. My Lord, in your recent direction, you asked core participants in their closing written submissions to focus on impacts that were foreseeable, significant, and which might have been minimised or elided had reasonable steps been taken so to do. And in these oral submissions, to highlight the matters core participants believe the inquiry needs to be addressed. The inquiry, having heard evidence over 53 days of this tranche of hearings, can be in no doubt as to the burden borne by the people of Scotland, and in particular those health and social care workers who looked after us during the most intense days of the pandemic and thereafter. Witnesses spoke to the loss of relatives and loved ones, others of the emotional trauma of being close to the passing of so many. I mean no discourtesy to those who have suffered bereavement as a consequence of COVID in raising, as I do today, the issues for Scotland's health and social care workers. There is no moral equation of suffering. For all who suffer, in whatever way, there is a personal, emotional and physical consequence and burden, one which can also impact on those nearest to us. My task, however, as others in the room will do today and tomorrow in respect of their own clients, is to advocate for those who I have the honour to represent, those who have worked or continue to work in our health and care sectors, including those who, having placed their own health on the line to protect others, find themselves the victim of a disease they sought to defeat. The inquiry has endeavoured to allow many voices to be heard in this inquiry, and that is to the inquiry's credit. There are no doubt many others who would have wished to have a voice, but it is recognised that there is a balance to be had between listening and acting, between considering and recommending. And as many of those that I represent continue to suffer in real and disabling terms from the effect of long COVID, the need for balance and for timely reporting is all too evident. So if these hearings have been about informing the inquiry about the reality of the nation's experience of COVID-19, I venture to suggest it paints a somewhat disheartening picture of a government not prepared for a pandemic, of institutions not resourced to meet the challenge that fell upon the nation, of panic and ineptitude at best in the implementation of protective and preventative measures, of confusion induced by poor communications, and of questionable, again at best, compliance with health and safety and equality laws. And finally, of an inconsistency in treatment of the health and social care workforce. And perhaps the most demoralising thing of all, when we consider the risks our health and social care workforce took as regards their own lives and health, a pervading professional, employer and potentially state scepticism that there are long-term disabling consequences from infection from a significant number of health and social care workers that is made manifest in not only personal economic suffering, but also the loss from the health and care workforce of those who remain capable of making some form of contribution. There are many areas where further investigation is necessary, but my task today is to highlight those worthy of attention from the point of view of the health and social care workforce. So let me be direct and identify 4 broad issues. Firstly, the immediate response. The inquiry has heard from witnesses as to the inadequate provision of PPE in the early stages of the pandemic, including of shortcomings in the assessment of the need for PPE masks generally, shortcomings in the provision of PPE, shortcomings in the assessment of individual need for PPE, shortcomings in the arranging of fitting of appropriate PPE, shortcomings in the need to identify the need for PPE based upon individual protected characteristics. These shortcomings were, I venture to suggest, entirely foreseeable in the absence of a plan, to use an expression which is currently in vogue. So was there a plan? The inquiry is charged to consider the Scottish Government's pandemic planning and to do so without restriction as to time. It must therefore look at the extent to which the Scottish Government considered, assessed and acted upon these foreseeable consequences. As the evidence suggests, there was no plan. The inquiry is also charged with considering the supply, distribution and use of PPE. Now that is constrained by the terms of reference to the period 1st January 2020 to 31st December 22. However, I submit to the inquiry that a proper consideration of the reasonableness of the supply, distribution and use of PPE during that period can only be made having regard to the arrangements, if any, that were in place and were capable of deployment on day 1 of that period. That, I submit, does justify the inquiry looking at the extent to which the NHS in Scotland, by which I mean the NHS Scotland centrally and individual health boards, were in a position to plan for, did plan for, and prepare to provide appropriate PE to protect the health and social care workers from an airborne virus, and also to ensure that it was fairly and appropriately provided based on individual professional need, individual personal and, where appropriate, protected characteristics, and individual susceptibility to the virus. Beyond planning, the inquiry must also look at how the provision of PPE was handled in the light of developing knowledge as to airborne transmission. Was the supply, distribution and use of PPE lawfully and fairly achieved at health board and health and social care employer level? The pandemic did not justify employers ignoring existing legislation on health and safety, discrimination or equality issues. So was there compliance or was there panic? Were those charged with ensuring compliance properly discharging their responsibilities? We implore the inquiry to look at these issues. I turn then to safe working environments. I've referred to PPE, but the health and well-being and resilience of our health and social care workforce, and thus the resilience of the country itself to manage the pandemic and the health and economic challenges it presented, turned to more than just the appropriate provision of PPE. Safe working environments were essential for the provision of proper care for those in receipt of health and social care services and for the safety and resilience of those who provided it. In considering the inquiry's responsibility to investigate the provision of healthcare services and social care support, including the support of staff, the inquiry is encouraged to consider the extent to which health boards and other public sector health and social care providers undertook timely, rigorously and properly informed risk assessments with particular regard to staff health and protected characteristics. Were those assessments reviewed as knowledge improved as to the effect of the pandemic was having on those with identifiable protected characteristics? And what of the workplaces themselves? The inquiry is encouraged when considering the provision of healthcare services generally and care and nursing homes handling of the pandemic to consider whether there was any prior or timely consideration to given and whether future consideration ought to be given to ensuring that in health and social care settings adequate provision exists to provide an estate that can properly provide a safe working environment in workplaces that pose risks from airborne infection during a pandemic. I turn then to occupational health. In my opening submissions to the inquiry, I referred to the debt owed by the nation to our health and social care workers, those who put their lives at risk in order to help those in peril, but find that they have succumbed to the very disease that they sought to protect us from, and who are therefore worthy of our utmost care and support. It is not the least disheartening aspect of the evidence that we have heard from health and social care staff who did not falter in their employment duties in the face of the virus, but who became infected and ill, to find employers who were ignorant, indifferent, or unsympathetic to their plight. And in that regard, I have particular regard to those who have or are suffering from long COVID. This inquiry has heard evidence of workers' frustration upon being told that because of insufficient testing at the start of the pandemic and the absence of an early positive test, long COVID could not be diagnosed despite symptoms otherwise consistent with long COVID. And further frustration at being told that whilst they may have worked in a COVID-19 rich environment, it can't be said that their symptoms were indeed as a result of occupational exposure, as opposed to exposure outside the workplace, on the bus, on the way to work. So my third broad issue, which I see as worthy of further investigation by the inquiry, is the extent to which in the provision of healthcare services and social care support, there was proper respect for health and social care workers to retain employment and continue to provide for the care and welfare of the nation as a whole. Were health boards and other healthcare and social care providers properly appraised of long COVID? For too many, the reality of a COVID infection has been the blight of long COVID. The research referred to by my learned friend Mr. Gale this morning would seem to confirm what has been the reality for many in respect of this illness. So in its planning, was the Scottish Government aware of that risk? Did it factor it into its planning? Similarly, did the NHS in Scotland do the same? Did the Scottish Government and NHS Scotland centrally inform health and social care providers of the risk? Did they take steps during the acute phase of the pandemic to ingather information, assess it, and provide information to inform decision-making at the employer level? Were occupational health measures fairly and proportionately deployed in the face of someone suffering from long COVID? Were fair and reasonable adjustments offered to the workforce returning to work? Did health boards, the NHS in Scotland more generally, and the Scottish Government reasonably and responsibly ingather, coordinate and disseminate learning as to long COVID to inform workplace risk assessments, work requirements and return to work arrangements? And was such work done and were steps put in place during the period of the terms of reference to ensure that such collaborative effort was effectively delivered? Significantly, I asked the inquiry, when considering the strategic handling of the pandemic, to consider whether there were deficiencies in the state's response that now justifies the recognition of long COVID as an occupational illness and the provision of welfare assistance to those who now suffer from long COVID. And that therefore takes me to my fourth broad area of concern, the extent to which long COVID is recognised out with the workplace, although the issues that I raise are perhaps of broader import. For those who have lost their employment as a consequence of long COVID, and for those who fear that possibility, there is a distinct issue as to the support provided to them by the state. For health and social care workers, the issue is particularly sensitive, for it may well be that their illness was caused by having to work in a health and social care environment in which COVID was present. For those, there may be difficulty in identifying that their illness is indeed caused by such exposure. The inquiry, in considering the strategic response to the pandemic, including welfare assistance programmes, should consider whether there is a case for the burden of proving an employment connection to lie not on health and social care workers, but on those who might otherwise deny such support. The inquiry heard much of its evidence in George House, the home of the Pensions Appeal Tribunal for Scotland, which hears appeals in respect of what we still, or perhaps with perhaps renewed relevance, call war pensions. We as a nation recognise the risk to those who place themselves at risk of injury to protect others. In providing pensions for our armed service personnel, the state has already inverted the onus of proving a service-related cause of injury to justify a financial award. It is not for our armed forces personnel to prove that an injury sustained during service was caused by service, but for the state to prove beyond reasonable doubt that it was not. That's part of the covenant between us and our armed forces. So I encourage the inquiry to consider whether there is justification for there to be a similar covenant between us and our health and social care workforce when it comes to pandemic-induced illness, to reflect the peculiar risks borne by our health and social care workers. Is there a case for a long COVID pension provision, and if so, in relation to health and social care workers, should the onus of proof of causation truly lie with a worker, or the onus of proof of disproving the connection lie with the employer? And finally, the ability of the country to look after and improve the lives of those with long COVID can only be enhanced by a proper understanding of the cause and effect of that illness, and that turns on the sharing of information nationally and internationally. The Scottish Healthcare Workers Coalition encourages the inquiry when considering the strategic response to the pandemic and the extent to which there was and is adequate provision for all healthcare services, to consider the extent to which the Scottish Government is actively engaged in gathering and assessing information relating to long COVID. So those are the primary issues we submit the inquiry may find as areas of foreseeable harm that are worthy, indeed cry out for further investigation. And we ask the inquiry to approach these issues having regard to three core issues: awareness, assessment and action. The inquiry should ascertain the extent to which the Scottish Government and the NHS in Scotland were aware of the issues that I have highlighted, what assessment was then made of those risks, and what action was taken in response. For in considering those three A's, one further can be resolved: accountability. I fear the inquiry will have to be robust in its investigations, despite the platitudes of willingness to assist the inquiry made in opening statements by public bodies such as NHS, NSS, with perhaps one, I think, notable exception. There is little assistance afforded to the inquiry in their closing submissions as to the specific issues that ought to be investigated. 2 or 3 lines after 53 days of hearings does not suggest a meaningful desire to assist. The Scottish Government itself can't be criticised for brevity in its written submission, but the inquiry will not have missed that its position appears to be that its objective was to contain and suppress the virus, and that the consequential devastating effects were, quotes, but a consequence of avoiding the harm caused by the virus. Did they not see that those consequences were harm in themselves? The inquiry will want to consider whether there was too narrow and blinkered approach by the Scottish Government. It's regrettable, standing the direction that your Lordship issued, that the Scottish Government has not directed the inquiry to lines of investigation that might demonstrate proactive and engaged government. The reference to...
Bring over time, Mr Webster, I have to tell you.
I'll bring it to you again, my Lord, then. The reference to a recognition of 4 harms, a need to build equality in decision-making, doesn't assist us in identifying where and how the inquiry will see how those issues are addressed. So, healthcare workers might also note the rather shallowness of the simple assertion the Scottish Government will simply reflect fully on the evidence. Simply to refer to one letter of an apology from the Cabinet Secretary to ambulance workers does not assist the inquiry in understanding where it might go and understand a sympathetic approach, or where it might go, in looking to find a sympathetic approach of government to the many challenges it faced. So at the start of the inquiry, I referred to how Scotland's healthcare workers had served the people of Scotland with courage and conviction. I referred to the risks they took, the physical and emotional trauma they bore, and that for many, frankly too many, COVID-19 continues to be an ongoing and real impediment to their lives. I called then on the inquiry to repay the nation's indebtedness to those individuals by robustly investigating and holding to account those who were responsible for strategic decision-making. And I called upon the inquiry to look to our decision makers and to ascertain what decisions were taken and why they were taken in the face of the pandemic. My Lord, with your indulgence, that remains the case, and I make no apology for reaffirming that expectation.
Very good. Thank you very much, Mr. Webster. Now, lastly this afternoon, we hear from Scottish women's rights organisations. Ms. Smeaton.
Thank you, my Lord. The Scottish women's rights organisations are made up of Close the Gap, Engender, Just Right Scotland, Rape Crisis Scotland and Scottish Women's Aid. As the inquiry is aware, these 5 organisations have grouped together for the conduct of this inquiry due to their common interest in gender equality and the protection of women, children and young people. The SWRO have lodged written submissions with the inquiry in respect of the health and social care hearings and fully detailed in those submissions their concerns about the impact of the pandemic on women and children across Scotland. I adopt those submissions, my Lord. This statement focuses on 4 key areas of concern in respect of decision making and impact, namely the lack of gender competence and failures to comply with equality law, resulting in foreseeable negative impacts on women's security, health, employment and their financial position. The first key area of concern is a lack of gender competence in decision making and widespread failure to comply with the requirements of the public sector equality duty. The SWRO submits that pre-existing structural gendered inequalities in Scotland, which already disadvantaged women, led to unequal negative impact and avoidable harm for women and children during the pandemic. These inequalities were worsened by a lack of intersectional gender competence in decision making across government and public institutions throughout the COVID-19 response. Decisions that do not take account of the differences in the lives and experiences of women and men exacerbate these inequalities. If it is to be effective, gender competence must be fully integrated into all public sector decisions. Considerations of gender and its intersections cannot simply be added on after decisions have been made, nor can gender analysis or an equality impact assessment be carried out as an extra step only when time or resources allow. Moreover, to be intersectional, decisions must take account of the intersecting drivers of inequality or disadvantage that contribute to women's overall experiences. And these include race, ethnicity, disability, age, socio-economic group and migrant status. Dr Scott of Scottish Women's Aid told the inquiry, "Gender incompetence operates with a male default, but a failure to understand that the male default gaze is built into decision making means that you make decisions that are deeply incompetent and harmful. For example, decisions around the procurement of PPE designed as standard to fit men failed to ensure that PPE was sized correctly to fit women's bodies and faces, and that it properly protected the majority of health and social care workers who are women. This meant that frontline workers were at increased risk of contracting COVID-19 in their workplace. Had structural inequalities been addressed before the pandemic, or if decision-making during COVID had been gender competent, the impact on women would have been very different." The SWRO encouraged the inquiry to consider all the evidence heard in the health and social care hearings through an intersectional gendered perspective, taking into account the different shape of women's lives, the sectors in which women make up the majority of workers, the role of women as primary carers for children and adults, and the foreseeable consequences of lockdown measures, all of which resulted in an unequal impact on women throughout the pandemic. The SWRO also encouraged the inquiry to investigate the compliance of Scotland's public bodies with the public sector equality duty. Amongst other requirements, the public sector equality duty as it applies to Scotland requires public bodies to mainstream equality and to undertake equality impact assessments in decision making. This requires consideration of the differences between women's and men's lives. Decisions that may appear neutral can nevertheless result in a detrimental effect on women. Despite being a legal requirement, there was a widespread failure to adhere to these duties during the pandemic. The SWRO believes that public bodies in Scotland ought to be held accountable for their shortcomings in meeting the public sector equality duty. The inquiry provides a key opportunity for public bodies to properly understand and to learn from the gendered impacts which resulted from public sector decision making, impacts which, in many cases, could have been avoided. Pre-existing structural inequalities harmed and continue to harm women, most commonly in terms of poverty and economic security, employment, access to justice and personal safety. These pre-existing inequalities could have and should have formed a basis for public sector decision making throughout the pandemic. The SWRO encouraged the inquiry to examine the exacerbation of pre-existing inequalities through the lack of intersectional gender competence exhibited by the government and other public bodies, and the failure to apply principles of equality law. The second key area of concern relates to domestic abuse and gender-based violence. The SWRO invite the inquiry to consider the impact of measures taken in response to the pandemic on instances of domestic abuse, as well as the effects of domestic abuse on women and children. Domestic abuse is a systemic problem, and the vast majority of victims are women and children, with between 1/4 and 1/3 of women in Scotland being affected by it. It is submitted that the number of victims alone ought to have meant greater care was taken to consider the consequences of decisions being made by public authorities throughout the pandemic. And instead, the opposite seems to have occurred. For example, the stay-at-home message overlooked that home was not a safe space for many, including for women who were experiencing domestic abuse. There was an increase in both the frequency and the severity of domestic abuse during the pandemic, and measures that kept those suffering from domestic abuse at home increased the opportunity for domestic abuse to be carried out, whilst at the same time limiting the ways in which victims could flee or seek support. Poverty, the lack of available refuge spaces and limited choices forced women and children to stay in unsafe homes, while lockdown restrictions ensured that they remained isolated and without access to services that might otherwise have recognised the signs of domestic abuse and provided help. For children, the places that they felt safest, school, nursery, or the homes of family or close friends were no longer available to them. As the inquiry heard, for women experiencing domestic abuse, it was a perfect storm. The SWRO's third key area of concern relates to the impact on women's health. The full impact of the pandemic on the mental and physical health of the population is not yet known. Significant health problems continue to affect many, and only long-term research will show the effects. But what is known is that women are twice as likely to report that their mental health worsened during the pandemic. This was in no small part due to the increased unpaid responsibilities which came to be expected of them in terms of childcare, homeschooling, and caring for vulnerable relatives, which were added to the strains of lockdown and home working, or to the pressures of continuing to work in public-facing roles in essential jobs. Women's higher levels of poverty and gender-based violence are also connected to adverse mental health impacts. For victims and survivors of domestic abuse, sexual violence and gender-based violence, the closure of the courts and resultant backlog of cases has meant significant delays in cases proceeding to trial. The SWRO have seen the hugely negative effects these delays have had on the mental health of victims and survivors, leading to increased stress and anxiety for women. And for health and social care workers, the vast majority of whom are women, The inquiry has heard numerous reports that their mental health and well-being was significantly affected by the pandemic. We also know that women are more likely to experience post-viral illness and are disproportionately likely to have long COVID, a condition which not only affects their current daily lives, but their long-term future, their earning capacity, and their financial security. The final key area of concern relates to the financial impact on women. The SWRO submit that pre-existing occupational segregation in Scotland drove the unequal impact of the pandemic, with women more likely to be employed in lower paid, unstable jobs. This included many women working in the health and social care sector and in essential retail, where they were at higher risk of contracting COVID, as well as working in sectors that were more likely to be shut down, such as hospitality. Throughout the pandemic, there was a significant increase in unpaid work as schools and nurseries closed and statutory services were severely curtailed. This moved the responsibilities of the state onto the shoulders of others, and those others were overwhelmingly women. Women took on a disproportionate amount of unpaid childcare, homeschooling, housework and caring responsibilities for vulnerable relatives. This increased the pressure on women, particularly if they were seeking to juggle these responsibilities alongside paid work, which was often not flexible, and this was particularly difficult for single mothers. The mental and emotional toll of this increased workload over a sustained period during the pandemic must not be underestimated. In conclusion, my lords, the SWRO submit that the inquiry must not only recognise the unequal impact on women during the pandemic, but also acknowledge the failure to foresee and mitigate against these unequal impacts. Women suffered disproportionately during the pandemic, and in particular those who were already in vulnerable situations or marginalised, such as disabled women, racially minoritised women, single parents, and survivors of sexual violence or domestic abuse. This outcome ought to have been predicted by public bodies, and it would have been avoided if equality impact assessments had been done at the outset of decision-making processes by those competent to undertake gender analysis. Instead, considerations of gender were either rejected outright as being superfluous, or at best were added or corrected following interventions from non-government bodies. The SWRO urged the inquiry not to subsume the experiences of women and girls within considerations of the population as a whole, but rather to recognise the structural inequalities which were exacerbated and the additional harms that women and girls suffered. Thank you.
Thank you, Ms. Beaton. Very good. That brings to an end this afternoon's proceedings and hearings. I'm grateful to all of you. I'm grateful, I should say, for the written submissions, which are of course far longer than the presentations you made this afternoon. As has been said repeatedly, they have all been considered and will continue to be considered and guide us in our continued deliberations. In the meantime, I simply adjourn until tomorrow morning. I check my paper at 10 o'clock. Thank you all.